Good evening, everyone. Welcome to our seminar about inflammatory bowel disease. Thanks, Dr. Zahra, for supervised on our seminar. This seminar presented by me and Faisal Mohammed and Abdulrazak Ma'moon. Protocol about the seminar. First, introduction. Second, ulcerative colitis. Third, Crohn's disease. Definition. Inflammatory bowel disease is defined as a chronic intestinal inflammation that results from host microbial interactions in a genetically susceptible individual. Inflammatory bowel disease also defined as group of autoimmune disease that are characterized by inflammation of both the small and large intestine, in which elements of the digestive system are attacked by the body's own immune system. Type of inflammatory bowel disease. Inflammatory bowel disease consists of two types: ulcerative colitis and Crohn's disease. Now, history of inflammatory bowel disease. In 1761, Morgagni provided a description of intestinal inflammation characteristic of Crohn's disease. After the identification of the causative agent of tuberculosis by Koch in 1882, it became clear that some individuals had disease similar to intestinal tuberculosis but didn't bear the tubercle bacillus. In 1932, the landmark publication of Krohn, Ginsberg, and Oppenheimer called attention to terminal ileitis as a distinct entity and chronic disease. What are the risk factors for developing inflammatory bowel disease? Smoking is one of the main factors for developing Crohn's disease. However, ulcerative colitis primarily affects non-smoker and ex-smoker. Age can happen at any age, but in most cases it starts before the age of 35. Gender. In general, inflammatory bowel disease affects both genders equally. Ulcerative colitis is more common among men, while Crohn's disease is more common among women. Family history. People who have a parent, sibling, or child with inflammatory bowel disease are at a much higher risk for developing it themselves. Ethnicity. Inflammatory bowel disease is present in all population. However, certain ethnic groups such as Caucasian and Ashkenazi have a higher risk. Now, Faisal talk about ulcerative colitis.
Assalamu alaikum, I'm Faisal Muhammad and I will continue talking about the ulcerative colitis. So what's ulcerative colitis? It is a type of inflammatory bowel disease that causes long-lasting inflammation and ulcers in your digestive tract, always involves the rectum and extend proximally in a continuous fashion to involve part or all of the colon. So ulcerative colitis affect the innermost lining, that means mucosa and submucosa of your colon and rectum. Symptoms usually develop over time rather than suddenly. Epidemiology of ulcerative colitis. In the United States of America, we have about 1 million people are affected with ulcerative colitis. It is more common in the Western and Northern Hemisphere. The incidence is low in Asia and Far East, and is 3 times more than in Crohn's disease. Females are more affected than males. Peaks of disease at age between 15 to 25 years and smaller one at age between 55 to 65 years. Causes of ulcerative colitis. We have firstly triggering factors such as diet, drugs, infections, stress, allergens, with genetic tendency that go for altered immunity and cause ulcerative colitis. So the pathogenesis of ulcerative colitis. We have firstly genetic factors. It is common in Jews, first degree relative, and identical twins HLA association associated with autoimmune thyroiditis and SLE. While environmental factors, it is common in non-smokers and ex-smokers. High refined sugar diet blamed as a risk factor for ulcerative colitis. The inflammation is due to activation of macrophages, lymphocytes, polymorph nuclear cells with release of inflammatory mediators like interleukins. So in the picture on the right, we have normal gut. With triggering factors such as infections and non-steroidal anti-inflammatory drug, we get acute injury and inflammation of the bowel that cause either tolerance and complete healing or chronic inflammation in genetically susceptible hosts. Morphology of ulcerative colitis. It always involves the rectum and extends proximally in a continuous fashion to involve part or all of the colon. So skip lesions are not seen, although focal, appendical, or cecal inflammation occasionally may be present. Disease of entire colon is called pancolitis, while disease limited to the rectum or rectosigmoid may be referred as ulcerative proctitis or ulcerative proctosigmoiditis respectively. The small intestine is normal, although mild mucosal inflammation of the distal ileum, backwash colitis may be present in severe cases of pancolitis. So we have the types of ulcerative colitis. In proctitis, it includes only the rectum, while in proctosigmoiditis, the inflammation includes sigmoid colon and rectum. Distal colitis including descending colon, sigmoid and rectum, while extensive colitis include transverse colon, descending sigmoid and the rectum. Pancolitis when all the colon is involved in the inflammation. Macroscopical features of ulcerative colitis. On a gross evaluation involves the colonic mucosa may be slightly red and granular appearing or exhibit extensive broad-based ulcer. Ulcers are aligned along the long axis of the colon but typically do not replicate the serpentine ulcers of Crohn's disease. Out of the full layer of the wall of the large intestine. The inflammation involves the mucosa and submucosa only. The mucosa look ulcerated and granular. With a severe attack, the mucosa become hemorrhagic. That means it bleeds easily and ulcerated. Isolated islands of regenerating mucosa often bulge into the lumen to create small elevations termed pseudopolyps. As we can see in the picture on the right, the pseudopolyps in the colon. Chronic disease may lead to mucosal atrophy and a flat, smooth mucosal surface lacking mucosal folds. Unlike Crohn's disease, neurothickening is absent, serous surface is normal, and strictures don't occur. However, inflammation and inflammatory mediator can damage muscularis propria and disturb neuromuscular function, leading to chronic dilation and toxic megacolon, which carry a significant risk of perforation. Microscopical features of ulcerative colitis. As we can see here in this picture, there is inflammatory infiltration, crypt abscess, crypt distortion, and epithelial metaplasia. However, skip lesions are absent, and inflammation is generally limited to the mucosa and superficial submucosa. While in severe cases, mucosal damage may be accompanied by ulcers that extend more deeply into the submucosa, but the muscularis propria are rarely involved. Submucosal fibrosis, mucosal atrophy, and distorted mucosal architecture remain as residue of healed disease, but the histological pattern also may revert to near normal after prolonged remission. Important note we have, granulomas are not present. Signs and symptoms of ulcerative colitis. For the signs we have pyrexia with dehydration, tachycardia with hypotension, abdominal tenderness, distension, or abdominal mass, while symptoms are weight loss, fatigue, abdominal pain, bloody diarrhea, tenesmus. Complication of ulcerative colitis. We have life-threatening complications like severe diarrhea and electrolyte derangement, massive hemorrhage, severe colonic dilation like toxic megacolon, with potential of perforation with peritonitis. Ulcerative colitis comes with high risk for colonic cancer. Diagnosis of ulcerative colitis. We have first a blood test to check for anemia or to check for signs of infection. Stool sample White blood cell in your stool can indicate ulcerative colitis, can also help rule other disorders. Colonoscopy to view your entire colon. Can also take a biopsy for laboratory analysis. X-ray and CT scan. X-ray, if severe symptoms, standard X-ray can rule out serious complications such as perforated colon, while CT scan of the abdomen or pelvis may also be performed if a complication from ulcerative colitis is suspected. A CT scan can also reveal how much of the colon is inflamed. And now my colleague Abdulrazak will continue with you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I am Abdulrazak Mamoun, and today I will introduce the Crohn's disease. At the first, how we can define the Crohn's disease is a type of inflammatory bowel disease that may affect any segment of the gastrointestinal tract from the mouth to the anus. The types of the Crohn's disease, according to the area that may affect it, there are 5 different types of the Crohn's disease, and I will explain that in the next slide. First, we have jejunolitis. Here we can see a part of the jejunum and the ileum is affected. Here we have an ileitis, as a part of the ileum is affected. And we have a gastroduodenal disease, or gastroduodenal Crohn's disease. We can see a part of the stomach is affected. And we have ileocolitis. Here part of the ileum and the colons is affected. And we have an Crohn's colitis, the part or segments of colon is affected. The most affected area by the Crohn's disease is ileocolic, followed by ileal, and the end is colic. So what's about the epidemiology of this disease? Is a worldwide distribution. The Crohn's disease is much more prevalent in the United States, in the Great Britain and Scandinavian than Central Europe, and is rare in Asia and Africa. In the United States, its annual incidence 3 to the 5 per 100,000 populations. It occurs at any age from the young childhood to the advanced age, and the peak of the incidence is between the second and the third decades of life. The female is slightly more affected than male, and the white skin is more affected than black. The Crohn's disease causes and risk factors. We have an genetics, or we have an smoking and autoimmune reactions, and we have an geographic locations, and we have non-steroidal anti-inflammatory drugs, antibiotics, and the contraceptive pill. Some scientific research that said that active smokers are more than twice as likely as non-smokers to develop Crohn's disease. So what's about the pathophysiology? Seriously, we will take it in general. When there is antigenic stimulations, like microbial or dietary antigens or other causes that affected on the intestinal mucosa, and that's lead to the activations of the gut immune system, and that's lead to normal physiological inflammations in normal person. But in the susceptible host, when they have environmental factors or genetic predisposition or other causes, that's lead to the uncontrolled inflammations, and that's lead to the extensive tissue injury, and finally lead to the Crohn's disease. In this seminar, honestly, we will emphasize about the pathohistological features of the Crohn's disease. So it's characterized by, first of all, sharply delimited and typical transmural involvement of the bowel by an inflammatory process with a mucosal damage. We have a presence of a non-gaseating granuloma in the 30 to the 60% of case. We have a fissuring with the formations fistula. So we will start it with the serosa. In the diseased segment, the serosa become granular and dull gray, and often the mesenteric fat wrap around the bowel surface. That's called the creeping fat. As we see below, there is comparisons between the normal intestine and the Crohn's disease intestines. And we can see the mesenteric fat wrapping around the colons. That's called creeping fat. Now, the wall of the intestinal wall is rubbery and thick. That's a result of edema, inflammations, and the fibrosis, and of course hypertrophy of the muscular subpropria. As a result, the lumen is almost always narrowed in the small intestine. And this is evidenced radiographically as the citrine sign, a thin stream of the barium passing through the diseased segment. Stricture may occur in the colon, but usually less severe. And the classical features of the Crohn's disease is sharp demarcations of the diseased bowel segment from adjacent uninvolved bowel. When multiple bowel segments are involved, the intervening bowel is essentially normal, and that's called the skip lesion. Here, we can see the skip lesions, and we can define it as wound or inflammations that is clearly patchy, skipping area that thereby are unharmed. So, what's about the mucosa? In the intestinal mucosa, early disease exhibits focal mucosal ulcer resembling canker sore. That's at the beginning of the disease. And we have an edema and loss of normal mucosal texture. But with the progressive disease, ulcer which causes or heal to be oriented along axis of the bowel. Here we can see a cobblestone appearance, and that's happened due to linear ulcerations. And the narrow fissure develop between the fold of a mucosa and often penetrating deeply through the bowel wall all the way to serosa. And that is lead to fistula or sinus tract formations, either to an adherent viscous to the outside skin or into a blind cavity to form localized abscess. So what's about the microscopic examinations? The inflammation with the nucleophilic infiltrations in the epithelial layer and accumulation with the crypt to form the crypt abscesses. We have an ulceration and we have a chronic mucosal damage, and the granuloma may be present anywhere in the alimentary tract. Here we have a biopsy from the patient with the Crohn's disease. We can see a fissure that extends from the mucosal to the muscle layer, and we have an ulcer in upper right, and we have lymphocyte aggregation of the lymphocyte. Here we have a biopsy from patient with the Crohn's disease. We can see the central granuloma. We can see knotted epithelial macrophages. Here, patient with a pyloric metaplasia and a numerous Paneth cell are noted in the depth mucosa of patient with the Crohn's disease. What's about the sinus symptoms? We have weight loss, we have fatigue, we have nausea, we have vomiting, we have abdominal pain and diarrhea and rectal bleeding. What's about the sign? We have pyrexia, we have dehydrations and abdominal tenderness and the tachycardia and the hypotensions, and maybe perianal lesions. The Crohn's disease diagnosis: we have a colonoscopy. We can make upper or capsule endoscopy, or abdomen CT scan, or blood test and stool tests. Now, the difference between the Crohn's and the ulcerative colitis. So, let's start with the depth of inflammations. In the ulcerative colitis, we just have a mucosal, but in the Crohn's disease, we have a transmural. The patterns of the disease: in the ulcerative is contiguous, and in the Crohn's disease skip areas. The locations in the ulcerative is a colorectum, and the Crohn's can affect any segment of the GIT. Rectal involvement in the ulcerative is usual, and the Crohn's is less common. Ileal disease in the ulcerative is backwash ileitis, 15 to the 20% of the patients, and the Crohn's disease is common. Fistula in the ulcerative colitis is rare, and the Crohn's disease is common. Perianal disease in the ulcerative is rare, and in the Crohn's disease is common. The granuloma is unlikely in the ulcerative, as about 10 to the 30% of patients have granuloma in any part of the alimentary tract. So the overt bleeding in the ulcerative is usual, and the Crohn's is less common. The malnutrition in the ulcerative colitis is unlikely, and the more common is the Crohn's disease. And the cancer risk, we have a colorectal cancer or cholangiocarcinoma if the primary sclerosing cholangitis is present. That is in the ulcerative colitis. But in the Crohn's, we have a colorectal cancer too, and a small bowel cancer, depending on the disease locations. In the tobacco use, in the ulcerative colitis, we have protective patterns, but in the Crohn's disease, we have harmful patterns. So, lastly, we have three specimens. We have normal, and the Crohn's disease, and ulcerative colitis. In the Crohn's disease, we can see there is fat wrapping around the large intestine, and we have thickening in the wall, and we have fissure. We have a cobblestoning in the mucosa. In the ulcerative colitis, we can see there is ulceration in the mucosa. There is no thickening of the wall. There is no wrapping of the fat, and we can see surviving mucosa that's called, or what's called, pseudopolyps. At the end, if you have any question, you can write it in the comment, and thank you for your listening.